Hey everyone, welcome to another deep dive where we unpack some dense medical topics to hopefully make them a bit easier to understand. This time we're tackling ulcerative colitis, and we've got some great info from UpToDate to help us along the way. So, if you're maybe prepping for a doctor's appointment or supporting a loved one with UC, or just curious about what it's all about, well, stick with us. We're going to break it down into, what UC actually is, how doctors figure out how serious it is, and of course the most important part, how to find the right treatment for different situations. So ready to dive in?
Let's do it. Ulcerative colitis, it's a chronic condition.
Yeah.
So that means, it's something you'll be managing long term. It causes inflammation in the lining of your large intestine and pretty much always involves the rectum.
It's more than just a simple stomach ache, huh?
Oh, yeah, definitely. This inflammation can cause a bunch of really unpleasant symptoms. Things like diarrhea, often with blood, abdominal pain, fatigue. But the thing is, it's not like constant misery. You see, it's kind of like a roller coaster. You have times when the inflammation flares up and then times of remission where things calm down.
Okay, that makes sense. But how do doctors even figure out if someone's UC is mild, moderate, or severe? I mean, pain's so subjective, right? What one person rates a 10 might feel like a 5 to someone else.
That's true. Pain is subjective. Doctors look at several things to determine the severity, like how often you're having bowel movements if there's blood, how you're feeling overall.
So like if I'm having maybe 4 loose stools a day sometimes with blood, but I'm not feeling too awful, no fever or anything, would that be considered mild?
Yeah, probably. Mild UC is usually defined as having up to 4 loose bowel movements a day. Maybe some blood, but you're generally okay. More annoying than debilitating.
Got it. What about moderate UC then?
Moderate UC is where things start to get more intense. You might be running to the bathroom much more often, seeing more blood, having more pain in your abdomen. You could even be a little anemic from losing blood. It's kind of like having a really bad stomach bug that just won't go away.
Oof, yeah, that doesn't sound fun. And severe UC.
Severe UC is when things get really serious. We're talking frequent bloody diarrhea, intense cramps, fever, and noticeable fatigue from anemia. It's like your body's in a full-blown battle with this inflammation.
Wow. So knowing where you fall in that spectrum, mild, moderate, severe, helps doctors figure out the best way to treat you right.
Precisely. It's all about choosing the right treatment strategy based on how active and how intense the inflammation is.
Okay, so we've got the severity down.
Yeah,
But what about how much of the colon is actually affected? Does that matter too?
absolutely. It's a big deal, actually. The extent of the disease, meaning how much of your colon is inflamed, is a major factor in predicting potential complications down the line, like whether you might need surgery at some point.
So how do they figure that out? More blood tests?
Nope. This is where a colonoscopy comes in. It's a procedure where they use a tiny camera to look at the lining of your colon and see exactly where and how much inflammation there is.
Makes sense. So
Correct.
what are the different, possibilities there?
Okay, well, imagine your colon is like a castle, and the inflammation is the enemy trying to take it over.
I like this visual.
Go on. So with ulcerative proctitis, the enemy is just at the castle gates, meaning the inflammation is only in your rectum. If they've managed to breach the first wall, that's proctosigmoiditis, affecting both the rectum and the sigmoid colon.
So basically it's like how far the inflammation is spread.
Exactly. Now, if the inflammation is more like a raiding party that's gone further up one side of the castle, that'd be left-sided colitis. And then there's extensive colitis or pancolitis where the enemy has taken over the whole fortress, meaning the entire colon is inflamed.
Whoa, okay. So knowing how much of the castle is under attack helps predict how things might unfold down the road, right?
You got it.
Yeah.
Someone with extensive colitis where the whole colon is inflamed might have a higher risk of needing surgery in the future. Compared to someone with ulcerative proctitis where it's just the rectum, it helps doctors think about the long-term picture.
Okay, so no one wants to think about complications, but knowing this stuff helps you understand what you might be facing down the road. Are there other sort of red flags doctors look for that suggest things could get more serious?
For sure. Besides the extent of the disease, other factors can point to a potentially more complicated course. For example, deeper ulcers. Those are like deeper wounds in your colon's lining. They can be a sign of more aggressive inflammation.
Okay, yeah. Deeper wounds, more trouble. What else?
This might surprise you, but sometimes being younger can actually be a risk factor.
Yeah.
Younger people with UC can sometimes have a more aggressive form of the disease.
Oh, wow, I surprising. I would thought the opposite.
It's one of those things. And then there are lab tests that can show how much inflammation is going on in your body overall. Elevated CRP and ESR, those are signs of a serious inflammatory battle raging inside.
So it's like checking the battlefield to see how intense the fighting is.
Perfect analogy. And if you need steroids all the time just to stay in remission, that's also a red flag. It means your body's struggling to keep the inflammation under control on its own.
Like you need constant reinforcements just to hold the line.
Exactly. And then, of course, if you've been hospitalized for UC in the past, or if you have other infections going on at the same time, those are also signs that things could escalate quickly.
So there's a whole bunch of clues that doctors put together to get a sense of how things might play out. But just because you have one or more of these risk factors doesn't mean you're doomed right.
Right. It's not a guarantee of a bad outcome. It's
No.
more like a heads up, a signal to work closely with your doctor and manage things carefully.
Okay, so let's talk about treatments. I know steroids are often used for UC, but I've also heard they can have some pretty nasty side effects. What's the deal with those?
Yeah, you're right. Steroids, or glucocorticoids as they're formally known, are powerful drugs. They can really quickly bring down inflammation, but they're not a long-term solution because of those potential side effects, especially if you need them for a long time.
So how do doctors figure out which treatment is right for each person? Does it depend on how they respond to steroids?
It's definitely part of the equation. Based on how you respond to steroids, doctors can categorize UC as glucocorticoid responsive, glucocorticoid dependent, or glucocorticoid refractory. Think of it like different levels of success on the battlefield.
Okay, I'm intrigued. Tell me more. What does it mean to be glucocorticoid responsive?
It means the troops rally quickly when those steroid reinforcements arrive, the inflammation goes down, and you start feeling much better.
So that's the best case scenario, right?
You bet. The steroids are doing their job, and you're responding well.
Okay, got it. What if you need steroids all the time just to keep the inflammation in check? What's that called?
We call that glucocorticoid-dependent UC. It means you rely on steroids to prevent the inflammation from flaring up again. And like we said, that's not ideal because of the potential for long-term side effects.
And then I'm guessing glucocorticoid refractory is the toughest battle of them all.
Sadly, yes. It means the enemy is resistant to the steroid attack, the reinforcements aren't as effective, and we need to find other weapons in our arsenal.
Okay, so it's clear that long-term steroid use is not the goal. What other options are out there for treating UC? Especially when you need to get that inflammation under control quickly. We need like a whole battle plan, right?
Exactly. That's where induction therapy comes in. Finding the right weapon, or sometimes a combination of weapons, to knock that inflammation out and get you into remission as quickly as possible.
Okay, so the initial attack to get things under control, how do doctors even decide which weapons to use? It seems like there are so many options out there.
You're not wrong. There is a whole arsenal of treatments these days, which is great news for people with UC, but it definitely makes choosing the right one more complicated.
So how do they narrow it down?
It's a very personalized process. Doctors look at a ton of different factors, like other health conditions you might have, your personal preferences, some meds or pills, some are infusions, your age, your risk of side effects from different treatments, what meds you've already tried, what your insurance will cover, and maybe most importantly, what the plan is for staying in remission once you get there.
So it's a team effort between you and your doc to figure out the best approach. But let's talk specifics. What are some of the weapons in the UC arsenal, so to speak?
One of the main groups of meds is called anti-TNF agents. They work by blocking a specific protein that drives inflammation in the body, kind of like cutting off communication between the enemy troops so they can't coordinate an attack as well.
Disrupting their chain of command, huh?
You got it. And sometimes doctors will combine anti-TNF agents with other meds called immunomodulators, like azathioprine 6-mercaptopurine or methotrexate if thiopurines aren't tolerated. It's like sending in a double agent to further weaken the enemy forces.
Sneaky. And are these anti-TNF agents effective?
They can be very effective for a lot of people, but like any powerful weapon, they can also have potential side effects. Your doctor will talk to you about those and help you weigh the benefits and risks.
Okay, what about vedolizumab? I've heard that one mentioned a lot.
Vedolizumab is another type of medication that works a little differently. It acts like a border patrol agent, preventing inflammatory cells from entering your colon in the first place.
So like setting up the strong defense at the castle walls.
Exactly. And one of the great things about vedolizumab is that it's often preferred for people who are at higher risk of infections or cancer, because it's more targeted to the gut and less likely to affect the immune system and the rest of your body.
Okay, less collateral damage.
Yeah.
What about those newer medications that target specific inflammatory messengers? The interleukins, I think they're called. The anti-IL antibody therapies.
Yep, that's right. Those are called anti-IL antibody therapies, and they're a really exciting development in UC treatment. There are a bunch of these meds now, like ustekinumab, mirikizumab, risankizumab, and guselkumab. They all work in a similar way by blocking those inflammatory messages, but each one has its own, quirks and might be a better fit for certain situations.
So it's about finding the right messenger blocker for your particular type of inflammation.
Exactly. Personalization is key.
Okay, and then there are those medications with the super long name, the sphingosine 1 phosphate receptor modulators. What are those all about?
Yeah, those are a mouthful. They're often called S1P receptor modulators for short. These are oral medications that work in a pretty complex way to reduce inflammation.
Right.
You could say they're like disrupting the enemy supply lines, making it harder for them to maintain their forces.
Clever. So are there specific S1P receptor modulators that are used for UC?
There are two main ones, ozanimod and etrasimod. And they can be really good at providing symptom relief quickly, which is a big plus.
So we've got all these different options for induction therapy, but what happens if the first one you try doesn't work? What if you don't achieve remission?
That's a really important question, and it does happen, unfortunately. It can be discouraging, but it's not a failure. It just means we need to adjust the battle plan.
So what are the next steps?
Usually the next step is to switch to a different class of medication, either another biologic or a small molecule.
Okay, and remind me, what are small molecules again?
No, molecules are a category of drugs that are small. They're typically taken orally, and one group that's used for UC is called Janus kinase inhibitors,
Right.
or JAK inhibitors for short.
And those are effective.
They can be very effective, especially for people who haven't responded to other treatments. But they also have a higher risk of side effects, so they're usually reserved for more difficult cases. Two common JK inhibitors are tafasitinib and upadacitinib.
So it's like bringing in the heavy artillery when the initial attack hasn't quite done the trick.
Exactly. And sometimes doctors might even recommend going back to intravenous steroids as a last resort if you haven't responded to oral steroids. It's not ideal, but it can be helpful in some cases.
And I know surgery is also an option for some people with UC, right?
That's right. Surgery can be a really effective treatment for people with severe UC or those who have complications that don't respond to medications. But it's a major decision, and we always try to exhaust all other options first.
Okay, so let's say we've found the right weapon or combination of weapons and we've achieved remission. We're feeling good, the inflammation's under control. What happens next?
That's when we shift our focus to maintenance therapy. It's all about holding the ground you've gained and preventing the inflammation from flaring up again.
So it's not like you can just declare victory and drop all your weapons, right?
Exactly. Maintenance therapy is crucial for staying in remission and avoiding those roller coaster ups and downs.
So what does maintenance therapy involve?
It often involves continuing the medications that worked for you during induction, sometimes at a lower dose or with some adjustments. But it's not just about medication. It's also about regular monitoring to make sure that inflammation stays under control.
What did that monitoring look like?
It usually involves regular checkups with your doctor blood tests to check for inflammation, and sometimes even colonoscopies to get a visual assessment of your colon's lining.
So it's like keeping a close eye on the battlefield to make sure the enemy isn't regrouping.
You got it. And remember those markers of inflammation we talked about earlier, like CRP and fecal calprotectin? Those are really helpful for monitoring, too. They can give doctors an early warning sign that inflammation might be brewing, even before you start feeling symptoms.
So it's like having an early warning system in place. That's reassuring. And what are some of the specific medications that are used for maintenance therapy?
Well, like I said, it often depends on what worked for you during induction. If you achieved remission with an anti-TNF agent, you might continue taking that long-term, possibly with dose adjustments or adding or removing an immunomodulator.
So it's about fine-tuning the strategy based on your individual response.
Exactly. And the same goes for vedolizumab and the anti-IL agents. If they worked well for induction, they're often continued for maintenance, with adjustments as needed.
But we know steroids aren't for long-term use because of those side effects. So what happens if you needed steroids to get into remission?
In those cases, the steroids would be tapered off gradually as you start a maintenance therapy that doesn't involve steroids. That might be a biologic agent or maybe a thiocurine.
What about those thiopurines we talked about earlier? Are those commonly used for maintenance?
Not as much as they used to be. They can be effective, but they take a while to kick in, sometimes up to 12 weeks, and they require regular blood tests to monitor for potential side effects. So with all the newer options available, thiopurines aren't usually the first choice.
Okay, that makes sense. So let's say you're doing everything right, taking your meds as prescribed, going to your checkups, getting those blood tests. But despite all that, the UC decides to rear its ugly head again. What happens then?
That's called a relapse, and it's unfortunately pretty common with UC. It can be frustrating and disheartening. But it's important to remember that it's not a failure. It just means we need to readjust the strategy.
So back to the drawing board.
Sort of. The first step is to rule out any other possible causes for your symptoms, like an infection. If it's confirmed to be a UC flare, the approach depends on several factors, including your past treatments and what medication you're currently on.
Okay, so it's back to that personalized approach again.
Absolutely. Sometimes a simple dose increase of your current medication is enough to get things back under control. Other times you might need to switch to a different medication in the same class, or maybe even a completely different class of medication. It all depends on your individual situation and how your body is responding.
So managing UC is really an ongoing journey, a constant collaboration with your doctor to find what works best for you.
You got it. It's a partnership, and open communication with your doctor is key.
So it sounds like managing UC is a lot more than just taking medication.
Oh, absolutely. It's
Huh.
about taking a holistic approach to your health.
So besides meds, what are some other things people can do to, help manage their UC? I've heard that diet can play a role.
You're right. Diet can definitely make a difference. What you eat can really impact your symptoms and how well you feel overall.
Okay, so what should people be eating?
Unfortunately, there's no one-size-fits-all answer when it comes to diet and UC. What works for one person might not work for another. It's really about working with your doctor or a registered dietitian to figure out what foods trigger your symptoms and what foods help you feel your best.
So another area where personalization is key.
Exactly. But beyond diet, there's also just taking care of your overall health. Making sure you're getting enough sleep, managing stress, and getting regular exercise can all help.
So it's like supporting your body's defenses on all fronts.
That's a great way to put it. And then there's another important aspect of UC management that we need to talk about, especially for people who have had UC for a long time.
Okay, I'm all ears. What is it?
It's called endoscopic surveillance for dysplasia.
Dysplasia. That sounds kind of scary.
It can be, but it's important to understand dysplasia refers to precancerous changes in the cells lining the colon. And because UC involves chronic inflammation in the colon, it can increase the risk of developing those changes over time.
So it's like the enemy is trying to sneak in a different way.
That's a good analogy. But the good news is that with regular colonoscopies, doctors can detect those changes early, when they're most treatable.
So those regular colonoscopies are really important for catching things early.
Exactly. Early detection is key.
Before we wrap up, I'm curious, are there any new and exciting treatments on the horizon for UC? Any secret weapons in development?
There's always exciting research happening, which is great news for people with UC. One area that's showing a lot of promise is fecal microbiota transplantation, or FMT for short.
FMT. That sounds intriguing. What is that?
It involves transferring fecal matter from a healthy donor into the colon of someone with UC. The idea is to repopulate the gut with beneficial bacteria, which can help modulate the immune system and reduce inflammation.
Wow, so it's like borrowing some good bacteria from a friend.
Exactly. And while it's still considered experimental, early studies suggest that FMT could be a really valuable tool for people who haven't responded to more traditional treatments.
So it's like calling in reinforcements.
You got it.
Well, this has been an incredible deep dive. I feel like we've covered so much ground, and I've learned a ton about ulcerative colitis.
Me too. We've gone from the basics of what UC is to how it's diagnosed and treated, and even touched on some promising new research.
And hopefully you listening out there feel a lot more knowledgeable and empowered to manage your own UC journey. Remember, knowledge is power, and the more you understand about this condition, the better equipped you'll be to work with your doctor to find the best path forward for you.
Couldn't agree more. It's all about being proactive, asking questions, and advocating for yourself. Don't be afraid to speak up. And make sure you're getting the care you need and deserve.
It's your health, your journey. You're the one in the driver's seat. Thanks for joining us on this deep dive into ulcerative colitis. We hope you found it helpful and informative. Until next time, stay curious and stay well.